Hello, everyone. We're going to get our next session started. Thanks for sticking with us through the afternoon here. I'm really excited to introduce Dr. Amy Hockenbrock to you all. She's a board-certified family medicine physician with a certificate of added qualification in primary care sports medicine. Dr. Hockenbrock's interests include sports medicine, LGBTQ care, and women's health care. Dr. Hockenbrock received her undergraduate degree at UC Berkeley, where she studied molecular and cell biology and led Cal's women's soccer team to multiple playoff berths from 96 through 2000. Sorry to age you. She received her MD from Chicago Medical School and then returned to San Jose for residency and primary care sports medicine fellowship at O'Connor Hospital. Following fellowship, Dr. Hockenbrock was an attending physician at Family Medicine Associates of San Jose before joining the West Coast Sports Institute. From 2018 to 2019, she worked for Planned Parenthood as interim transgender program director for the Mar-Monte region. Through this experience, she was able to combine her sports medicine knowledge with her expertise in transgender care. Dr. Hockenbrock recently rejoined the Cal community and got a promotion recently, and now is Associate Medical Director, bringing her skills in sports medicine and gender-affirming care to UC Berkeley. I'm very excited to have Dr. Hockenbrock speak to you on this timely and incredibly important topic. I've had the privilege of hearing her speak on this topic, and I could think of no one better to discuss sports medicine considerations for the trans athlete with you today. Please join me in welcoming Dr. Amy Hockenbrock.
Thank you, Gina, and thank you all for having me. Thank you, UCSF, for having me. This is a topic that I'm very passionate about. I've done a lot of work in this area, so I always appreciate having the space in order to talk to others about it. This picture on the front is a tree from the Monteverde cloud forest in Costa Rica, and I put this here so that we all remember the importance of diversity in our world and the importance of diversity in a forest, but also the importance of diversity within our athletics and within sports medicine itself. So again, I am Amy Hockenbrock. I use she, her pronouns. I'm the Associate Medical Director at UC Berkeley for the University Health Services. I also am an Associate Team Physician. So thank you for being here. I have no financial interests. So when I talk about this topic, there's always a few slides that I do always bring up. And the first is why. Why are we here? I can tell you why I'm here. I am not trans. I am an ally. I'm a family medicine and a sports medicine trained clinician. I believe in the ability to take care of all patients within primary care, but also within sports medicine. Part of that is having this knowledge, and that's why I'm grateful for you all to be here. I believe in providing care for all marginalized groups, of which transgender and gender diverse athletes are part of a marginalized group. I have been the interim transgender director at Planned Parenthood Mar-Monte, and I have been the trans care team co-lead for UHS at UC Berkeley. Again, I believe in providing care to all, including all of our athletes, no matter how they identify gender-wise, so I appreciate you being here. Why are you here? In this, you can be in other areas right now. You can be enjoying your Saturday. Many of you are here because you're curious. You kind of want to learn something about this subject. If you feel that you're part of a sports medicine team and you want to take care of all of your athletes, regardless of their race, socioeconomic level, their gender, you're in the right place. If you feel you're part of a sports medicine team and your job is to take care of every person that comes through your door, you are in the right place. If you feel that your job is not to judge patients, agree, nor disagree, just provide your medical care, you're in the right place. And if you feel like you want to do your job to the best of your ability, no matter what our political climate is, you're in the right place. Thank you for being here. Please stay, learning about areas that make us uncomfortable, make us better. So learn, open your mind, ask some questions. Most of you know, or at least have seen our gender unicorn before. I'm not going to go into all aspects of gender. This lecture, as you'll watch me try to race through it, is multiple lectures kind of all put into one. I will kind of go quickly over this stuff that is very much covered in many other lectures. But whenever we talk about gender, we always have to do a self-check-in. How do you feel about gender sitting here? This is going to matter as to how you're going to take in this lecture and what you're going to bring out of this lecture hall. What comes up when someone talks about gender diversity or gender affirming care? Is there anything you're afraid of in regards to gender gender or providing care for gender diverse people? What is your resistance, if you have resistance, to increasing your inclusivity? Before we can provide the best care, we always must check in with our own experience and our own internal bias, always remembering that with everything we do, but especially in regards to gender. So are transgender athletes new? No. Gender diversity and trans athletes have been around for a long, long time. These are 4 notable trans athletes that do a lot of work in this space. On the top left is Renee Richards. Renee is a 1970s tennis athlete. After her transition, the U.S. Tennis Association began requiring genetic screening for female players. She ended up refusing, sued the USTA, and won, and continued to play and coach after that time. That was in the 1970s. The next athlete on here is Chris Mosier. Chris is the first transgender man to represent the U.S. in international competition. Chris is a dual athlete. Chris runs transathlete.com, which is a huge resource, which I'll talk about a little bit later. Chris has worked tirelessly in working with the IOC and their policy. The next athlete is Laisha Clarendon. Lay is the first openly transgender and non-binary athlete to play in the WNBA. Lay won a gold medal in the 2018 FIBA Women's Basketball World Cup. Lay is a Cal grad, go Bears, an advocate for LGBTQ plus people in sports, and won the Out Sports Female Hero of the Year. And last, we have Leah Thomas, who's a 22 Penn swimmer. Leah transitioned from male assigned at birth to female, and this attracted a lot of media attention in 2022. That might be a lot of the reason why some of you are here today. She won the 500-yard freestyle event at the NC2A Championships in 2022, making her the first out trans woman to win an NC2A swimming championship. So trans athletes are not new. What is new? What is new is there's more anti-trans and anti-LGBTQ legislation bills throughout our country. In our political climate, these medical treatments and participation in sports have now become a part of political platforms, and that's new. That's the new part, not that we have athletes that are gender diverse in our sports. So we're not going to go into that, but we are going to go into how do we care best for our trans athletes and gender diverse athletes. So part of this lecture, we're going to talk about basic hormones for gender affirming care. Many of you might provide gender affirming care. I apologize if this is stuff you do every day, but I do think it's worthwhile for everyone to have a base knowledge for this. We're going to review current medical concerns regarding gender affirming hormones in athletes. We're going to look at some of the participation rules and regulations in various levels of sport. And finally, if we have time, and I hope to, we're going to get to 5 different literature reviews. There's not a lot of literature on this subject, but I hope to touch on a few of them. So big 50,000-foot view on gender-affirming hormones. There's a person who is assigned a female at birth but identifies as male masculine. Many times we say transmasculine, transmale, transmasc, FTM. All of these words can be used. A person who's assigned male at birth but identifies female or feminine. We use transfeminine, transfemale, male to female, transfemme, many different words. When we look at transfeminizing and transmasculinizing, we really look a lot at testosterone and estrogen. For transfeminizing, our goal is to lower our T, or our testosterone, and raise our estrogen. So we use estrogen and spironolactone for transfeminizing. Estrogen alone will not lower a T level. That's why we put spironolactone in there. These are typically given orally, sublingually, intramuscular, or sub-Q injections. A lot of times we'll do a staggered start for better breast development. If someone has an orchiectomy, we don't need to continue with the Spiro, and these medications are lifelong. Many times we'll add progesterone with this for various reasons. When we are talking about transmasculinizing, our goal is to raise our testosterone and lower our estrogen. Testosterone is generally given in injectable form. There are gels, there are implants that we use as well. Just with testosterone, estrogen will go down, so we don't have to have a dual medication there. And again, these medications will be given lifelong. Transitioning, every transition is unique. There is no gold standard way to transition. We cannot put this into a pretty box like many times we want to. There's many common methods, there's timelines that we use, but every transition is unique and every body will take hormones in a slightly different way. Again, overall, we're basically dealing with only two of our hormones, estrogen and testosterone. There's a lot more hormones in our body, generally a titration, and most of the changes take up to 5 years. These are very kind of big 50,000 foot view. If you have interest in providing gender affirming hormones, that's a whole nother lecture we can do. So what are we worried about? If we have an athlete that is masculinizing, so taking testosterone in some form, what are we worried about as a sports medicine physician? So most of the time when we're giving testosterone, we're worried about prostate stuff. These athletes don't have prostates. We don't have to worry about that. We're not worried about prostate cancer. We're not worried about BPH. There generally is a erythrocytosis, so hemoglobin hematocrit goes up to what we would call a cis-normative level. So it's not going higher or to a super therapeutic level. We are kind of sticking in the cis-normal range for erythrocytosis. We always worry about venous thromboembolism, cardiovascular risk with both hormones, testosterone and estrogen. But remember that we are not having our patients at a super therapeutic level. We are hoping our patients' levels are going to be where a cis male levels testosterone would be in this. So whatever you worry about with a cis male in regards to their hormones, this is what you would be worrying about with a trans athlete that's masculinized. There's always injection site skin irritation if they are injecting the hormone, and then dry mouth, fainting, lightheadedness, liver. These medicines are processed through our body. Whenever we talk about testosterone, it's really important to realize the units of measurements that we do. Most of the time when I get a lab back for testosterone, it's in nanograms per deciliter. Most of the time our policies are quoting nanomoles per liter. These are different numbers. You're going to see the numbers come around. So just make sure you realize there's two levels. When I'm giving someone gender affirming hormones to masculinize for full masculinizations, the numbers I generally want someone to get towards is between 700 to 900 nanograms per deciliter, which is about 24 to 31 nanomoles per liter. So again, that second number is what I want you to remember when we start to look at some of the policies. Transfeminizing, generally we want your T very low, and so less than 50 nanograms, which is 1.7 nanomoles, so a very low level. Let's look at feminizing. When we're looking at feminizing, we're talking about estrogen and trying to lower that testosterone. Again, many times with estrogen, we worry about endometrial changes, ovarian cancer, endometriosis. These patients don't have ovaries or uterus most of the time, so that's something we don't worry about. There's less of a concern for breast cancer. Really, there's not a lot that's been studied in regards to breast cancer in trans women. Again, VTE, cardiovascular, we worry about that with all hormones. Same thing, though, we're not asking people to be in a supratherapeutic level compared to cis-normative numbers. We're asking them to be in a cis-normative area, which for estrogen is between 100 and 300. Dementia is something we do worry about with people that take estrogen. This, again, we're not going super therapeutic, so this is what we would worry about with all cis women that have estrogen in their body. Injection site irritation, dry mouth, fainting, lightheadedness, and liver. These are all being metabolized through our body. The one medicine when we talk about gender affirming hormones that is good and is important to note with athletes, spironolactone. Spironolactone is something that we use that lowers testosterone. It's also used often for blood pressure and acne. You will see it often. It is, again, we're using it for lowering testosterone in this case. One of the concerns with spironolactone is that you can have gynecomastia. Again, most of the time that's an added side effect that our patients want for trans females. Metabolic abnormalities like hyperkalemia happen. This is something along with hypovolemia, orthostatic hypotension, getting dizzy, cramping. These are big things that make a difference for our athletes. This can be on the field. So if someone is feminizing and on Spiro, it's good for you to know that they might be cramping or they might need more potassium. These are processed through our body, so liver and renal changes, and then fainting, lightheadedness with all of our hormones. That's really the medicines we use with gender affirming hormones. So many times people ask me, what should I do differently? This is a trans athlete. Not a whole lot. If you have a cis athlete that's on Spiro, it's a very similar thought process that you should have in your head. So how do we take care of transgender and gender diverse athletes? We take care of them as we always would. Common sport injuries, shoulders, knees, hips, concussions, we do that. If someone's having surgery, maybe look at their medications, make sure things are kind of where they need to be. Medication compliance in sport. If medication they're taking is a banned substance, that's something that you might need to help with paperwork and make sure that kind of all the rules and policies are being followed. You might be the one providing gender affirming hormones. Many primary care folks and clinicians do that, so that's something you might be doing. Medication side effects that we discussed. And then finally, this last one, which we're going to spend some time on right now, is helping ensure our athletes are compliant with their sport or league policies, which is one of the biggest roles as part of a sports medicine team. So when we look at participation policies, there's a lot. There's all different levels. It's hard. We're going to go through each level and we'll talk a little bit about all of them. When we look at policies for gender inclusion in sports medicine and in athletics, early life and kind of elementary school through 8th grade, gender was fluid, especially at the younger ages. Soccer is kind of not binary at that age a lot of times. You'll see T-ball not binary as well. But now there's a lot more movement towards making these sports, even at very young ages, binary. Previous policies were all about inclusion. Now there's even some states that ban full trans athletes from participating even at the young age of 4 or 5. So what you need to know is that depending on the league or the school or the state that you're in with this younger age group, you need to know. You need to know what the laws are. You need to know if there's participation policies. This is how we can help our athletes be part of sports. High school is getting a little bit different, one step up. Depending on the state and the funding of the schools, there's kind of more restriction compared to years ago, but some places not as much as well. The NFHS, which is kind of our National Federation of High School Sports in the United States, puts it on schools and districts for them to have their own policies. And so with that, every school and district and state might have different policies. So depending where you're helping out, where you're working, you want to be aware of what those policies are so that if you have a gender diverse athlete or a trans athlete, you can help them make sure they're able to participate. Significant state by state variety, as we've all seen. In the state of California, we have a very inclusive gender identity participation. And really this is the CIF, which is our governing body for California Interfederation of Sport for the high schools in California. Really, we believe in kind of inclusion for as many athletes as possible. And this is much more of this is guided by a state law called AB 1266. And the state law really says a pupil shall be permitted to participate in sex-segregated school programs and activities, including athletic teams and competitions, and use of facilities consistent with his or her gender identity, irrespective of what's listed on the pupil's records. So it's based on gender identity in the state of California because of state law. And that's what we lean back on for most of our high schools here. If anyone needs extra information, there's a gender diverse youth sport inclusivity toolkit on the CIF website that can help with schools that you might be working with. We're going to go one more step up and we're going to look at college athletics. College athletics is a big term. There is a lot of athletes and levels within the term college athletics. So when we look at it, there's Division 1, 2, 3, there's club sports, there's rec sports, there's others. All of these are going to be bound by different rules and regulations. Many of our sports are going to operate under the NC2A. Many might operate under the NAIA, which is another governing body. Many of our our athletes might be competing in competitions interstate. So as they go into another state, state laws might come into effect, even though their school rules are different than what those state laws are where they're competing. And as we've all seen with conference realignment, sometimes that travel is significant. So you're going to states in very other parts of the country. So as you're looking at participation, all of these things come into play. When we look at sports medicine in regards to trans athletes and gender diverse athletes, there's a lot of complicated aspects. We can make them simple, and this kind of speaks to some of the complications of it. The NAIA in August of 2024 put out their transgender participation policy, which essentially is not being allowed to participate. Essentially, a transgender athlete in the NAIA can participate if they are not on gender affirming hormones, or if they are, they can do internal activities, they just can't compete. So essentially a very limited policy. The NC2A has had a policy that we're now currently in phase 2 of, and it's called the Transgender Student Athlete Participation Policy. And as of May of 2024, we're going to stay in phase 2. It was supposed to move towards phase 3, but they've decided to stay at phase 2. And really what this shows is they're kind of leaning on the way the International Olympic Committee has structured their transgender policy, and it's really a sport by sport approach, leaning on the national governing bodies for each sport. So for a transmasculine student athlete, they have to submit a medical exemption to take testosterone. Testosterone is a banned substance, so we have to do a medical exemption for that. And then we have to get 3 testosterone levels throughout their year. So twice per year, essentially, and then 1 prior to an NC2A championship event. For trans feminine athletes, there's a transgender eligibility review form that needs to be filled out by a clinician, which might be some of you in this room. And then there's a one-time testosterone level that needs to be done, and then a prior to competition season or championship. So essentially 2 total. So these are the rules they've put in place. So whether sometimes rules being put in place are hard, or we agree or disagree, it's nice to have a set of rules so that our athletes can participate within a set of rules. So if you look at the bottom of the screen here, you can see this is, for example, for each sport that has a policy, which most do now. This is field hockey's. Essentially, they say what the sport is, what your approved testosterone threshold level is. So this one, for instance, says that when those levels are checked, it needs to be less than 10 nanomoles per liter. And again, that would be essentially 3 times per year. They tell you what the policy is benchmarked on, which is on this 2015 IOC policy, and they tell you the deadlines those levels need to come back at. This is one example. This is field hockey. If you remember from when I talked about testosterone, being under 10 nanomoles per liter is very doable. Most of the time for me, my patients are around 1 or 2 nanomoles in that regards. On the left here is for a trans feminine athlete. This is what the transgender eligibility review form looks like, and it's essentially asking the clinician to sign off on some of the things in this. So I tell you this, that there is a way to compete in the NC2A. There is a way the NC2A has asked all of us to do this. It is complicated, but it is there. I do want to talk a little bit about Cal. At Cal, our athletics, we believe in inclusion, and we have an inclusion statement that's been around since 2015. So this is nothing new for Cal. We prohibit discrimination, and really based on many things, but including gender identity, expression, and genetics. And really what this tells is that all individuals are guaranteed the right to equal access and equal opportunity within our athletic department. We believe strongly in that. We have had a transgender and gender diverse student athlete policy for many years now. People before my time have created a wonderful policy, one of the first in the nation. We had to adapt it because of the NC2A putting out this phased approach. And really the way we adapted is we created a transgender student athlete diversification participation board. I know that's a mouthful. Really what this means is if I have an athlete that comes into my office that has some gender concerns with hormones, without hormones, with some sort of inclusivity or barrier that's presented, we pull together the board to figure out how we can lower that barrier. So our main board consists of an NC2A compliance officer, someone from our Gender Equity Resource Center, Title IX compliance office, and a team physician who's knowledgeable about WPATH and SOC8, which is our gender affirming hormone guidelines. With that, sometimes we have adjunct members, and Every transition is different. Every athlete in regards to their transition may or may not need different things from us or want different things from us. Sometimes we have conversations and the athlete doesn't want to do anything. Sometimes there's only very specific things that the athlete feels that are barriers to them and their gender identity. So sometimes we'll have a mental health clinician there. Sometimes we'll have someone from the athletic director's office or from the faculty athletic representative. Sometimes we'll have someone from the Office of Legal Affairs. Sometimes a coach or coaching staff will be there. Sometimes a student athlete themselves or a student athlete representative. And I tell you this is the way that we figured out that we can help our athletes in regards to barriers, in regards to allowing them to work through things in an individual and unique way, while making sure that we're knowledgeable about the NC2A guidelines. The other thing that I do want to note is that every sport is different in regards to the numbers, and every student athlete is different in regards to the hormones they're on. And so when you're looking at kind of a one-size-fits-all, it's very difficult to do with this, but this approach allows us to kind of take each one on a case-by-case basis and really making sure that we're meeting the needs of our athletes. Now let's go one step higher into the Olympics. So the Olympics has been dealing with gender diversity for a long time, much earlier than the NC2A, at least openly. And so in May 2021, the IOC updated some of their inclusion policies. And really what they created was a framework for fairness, inclusion, and non-discrimination on the basis of gender identity and sex variations. And really what this shows, again, they kind of punt it back to each sport and to each of those national governing bodies. And they said, you need to come up with something that works for your sport, that allows people to not have a disproportionate advantage, taking into consideration the nature of your sport. But here's the framework we'd like you to do this within. So it needs to be inclusive. There needs to be a prevention of harm. There needs to be non-discrimination. There needs to be fairness. There needs to be no presumption of advantage. Just because somebody looks some way or is taking something, we don't just presume that's an advantage in the sport. It needs to be evidence-based, and that'll be the last part of this talk, is really looking at what evidence do we have. There needs to be a privacy of health and bodily autonomy, stakeholder-centered approach, a right to privacy, and then we need to be able to review it, periodic reviews. So again, this is a framework, and then each sport and their national governing body and international governing body is coming up with kind of what works for them. This is Laurel Hubbard of New Zealand during the weightlifting competition in the Tokyo Olympic Games. Laurel was the first openly transgender woman to compete in the Olympics in 2020. So again, when we're looking at this overall concern, kind of one of the biggest aspects that I find that our role as a sports medicine team is helping ensure our athletes are compliant with these policies. This is transathlete.com. This is Chris Mosier's website. One of the best parts of this website is he has policies for all of as much as he can, and it's constantly being updated. So if I have a person in my office that's Quidditch, say they play Quidditch, I'm like, I don't know if there's a policy. Then I can go to transathlete.com, look up that area, look and see. And a lot of times you'll be shocked to say there is a policy, great. If there's not a policy, that's fine. But if there is a policy, we want to make sure we're abiding by it so that we're giving more access to our student athletes. All right, let's move on to a little bit of the studies. We're going to go through 5 studies. You'll realize the shortcomings of a lot of these studies, not because it's the author's fault, but because it's very hard to study this topic. Most of these studies are trying to evaluate testosterone and estrogen and really what defines your sex in sport. And all of this kind of comes together. All of us have both. All of us have some testosterone and estrogen. And is there an ideal combination for a particular sport at a particular time? It's complicated. Those levels are going to change throughout our life. They're going to change throughout a transition. They're going to change no matter if you transitioned pre-puberty or post-puberty. And it's really trying to figure out what amount of hormones makes you great at your sport, and how do we put that into our binary gender sport box that we have right now, which has been difficult. If those of you want more information, this book, Fair Play by Katie Barnes, is fantastic. Some of this research comes from this book. So first study here, this is the first study that is really looking at hormones in regards to gender. And this is one of my favorite studies due to its simplicity. So 2014, M.L. Healy, really looking endocrine profiles in 693 elite athletes in the post-competition setting. And really what this author did is they went and they asked for volunteer athletes within 2 hours of a major national or international competition. They had to be, quote, elite athletes, and they got a very large N, 446 men and 234 women. These are cis men and cis women. So this is not a trans athlete study at all. Of note, the sports are all over the place. Swimmers, power lifters, ice hockey. And what I find most interesting, so the top here is the serum testosterone in cis male athletes within 2 hours of competition. And on the bottom is testosterone levels within female athletes within 2 hours of competitions. So you can see there's a nice little bell curve on the males, and the females, it's very, very together down here. But we have outliers. So this gray box on both of those is what's considered normal for in our cis normative values. So you look on the top, yeah, most of them are falling within normal. There's some significantly lower when we look at their testosterone levels. There's some that are set definitely higher, and these are cis males. Now when we look down at the women, yes, the majority are in what we consider the cis normative values, but there's some women that have a pretty high testosterone level. They are not taking exogenous testosterone. This is just their testosterone level randomly checked as an elite athlete. And what it begs the question is, so we have this nice study. It's a very simple study, but very interesting in that because this, these are groups of multiple athletes, but say this group of athletes down here, does this level inherently make them a better athlete than, say, a level of 0 to 4 down here in our cis male levels? Again, complicated. The second study that we'll talk about is done by Joanna Harper. So Joanna is a distance runner. She ran in college, and then she medically and socially transitioned after college. And she noticed within weeks, her times were getting significantly slower. And at 9 months, she claims that her times were 12% slower. And she felt that she lost her, quote, male advantage within 9 months of being on feminizing medications. She then reached out to other transgender distance runners. She was a medical physicist herself, and she said, hey, send me your times. I just want to see kind of where your times are at for as long back. So again, the N is 8. 1 is her, and 2 won't identify themselves. So it's very hard just due to fear of and transphobia and stuff. So race times over 7 years, and really kind of they did age grading, which sometimes is used to it in running. But essentially the conclusion was that transgender women after gender-affirming hormones were more athletically similar to cisgender women in regards to hormone levels, hemoglobin levels, and in race times. Again, this was the very first transgender athlete study, an N of 8, very low numbers, but this is some of the evidence that's being used when we're making these policies. Let's go to our next study here. And again, we just have 5 so that I hopefully will have time for questions. This study was in 2020. Again, these are very recent studies that we're doing here. This one is the effect of gender-affirming hormones on the athletic performance in trans women and trans men. Again, sometimes it's so fun when you see these beautiful study designs. But this is 29 trans men and 46 trans women in the Air Force. They transitioned while they were in the Air Force. So what is really nice about this study is they have their data from before they transitioned and their data from after, from all of their fitness tests and whatnot. And so, again, this talks to the complication of it, but transgender men equalized their sit-ups, push-ups, and 1.5 mile time and compared with control men, so cis men, after 1 year of gender-affirming hormones. So these people all transitioned after puberty, and they're comparing them to a set of cis men in the Air Force. Transgender women equalized their sit-ups, push-ups, but remained 12% faster in the 1.5 mile time 2 years after starting their gender-affirming hormones. So to me, again, a beautiful study. They were able to have this data from before and after, very objective numbers in regards to sit-ups, push-ups, and a 1.5 mile time. How does this lean into your sports and your athletes? It's hard. Does a 1.5 mile time make you an elite swimmer? I don't know. All right, so the next one is 2022 by Alvarez, a small study. So the N is only 29. And really the title is Cardiopulmonary Capacity and Muscle Strength in Transgender Women on Long-Term Gender-Affirming Hormones. And really what they were trying to say is if there is a testosterone-driven puberty and somebody transitions after testosterone-driven puberty, can they see a difference in strength? Again, a small N, and this is looking post-puberty. And kind of really what this shows is that they were looking at bioimpedance, hand grip, and then cardiopulmonary exercise testing on the treadmill was done. And it's essentially none of those levels actually normalized. And by normalized, I mean go back to cis athlete levels. But when they adjusted for fat-free mass, everything normalized. Finally, our last study was 2024, so a pretty recent study. And this, we're looking at 12 transgender men and 23 transgender women. And really, this was looking at strength, power, and aerobic capacity of transgender athletes. This was a cross-sectional study, and it was really comparing cisgender men and women to transgender men and women. They looked at lots of different things: testosterone, estrogen, hemoglobin, lung function, grip strength. There's a lot of grip strength in these studies, I think really because it's an objective, easier to study thing. And then they looked at some kind of body movements with jumps and body composition. And what did it show for us? So transgender women have a lower FEV1 to FEVC ratio, lower jump height, and a lower VO2 max, but a higher grip strength compared to cisgender women. And transgender men had a lower testosterone, a lower grip strength, and a lower VO2 max compared to cisgender men. So in this study, things didn't come back equal, but some of them actually came back lower, and then some came back higher. So they're not going exactly back to cisgender levels and various things depending on the study. So what do I bring for conclusions out of this and what these policies are being based on, and how do we treat people? Is that evidence is hard. Evidence-based decisions in regard to transgender and gender diverse athletes, it's difficult, it's complicated. Trying to simplify it and put it into a box is not easy. Questions that need to be asked is, are we looking at pre-puberty levels or after a testosterone or estrogen-driven puberty transition? How do we know what their baseline athletic ability is when we're looking to compare if things have changed? Are we studying a specific sport? So does grip strength actually relate to a soccer player's athletic ability? Or are we just generalizing this for all sports? What are we using as our control group? A control group of cisgender women or men athletes. As we all know, our athletes generally are not falling into averages. Does a governing body get to add to know an athlete's medical history in regards to gender? And then how does the inability for gender, when we look at policies, there's some policies coming out that want people to transition before puberty. When we look at that, when that transition is now against the law in certain states, how do we allow those athletes to participate in their states? And really this kind of brings to question a lot of things in sports medicine, a lot of things in inclusion, a lot of things, but really kind of gets to the point of what makes you a great athlete. Is there one thing? Is it our testosterone level? If my testosterone level is high, am I a great athlete at all things? Is it my height? Is it my wingspan? Is it I'm really good at focusing? Is it my hemoglobin levels? Is it how much money my parents have? Because I've had a lot of private trainers, or I've had a lot of good club teams that I've been on. So when we're looking at trying to make things fair and equitable and inclusive, I just get back to the point that it's complicated. So when we continually try to put all of this data into a nice little box, I would love it if it were that easy, but hopefully this has shown you that things are a little bit more complicated with gender diversity in sports. So in summary, transgender and gender diverse athletes, they're not new. They remain a marginalized patient and athlete group. Understanding gender affirming hormones, and again, I know I did a fast 50,000 foot view of gender affirming hormones, but understanding kind of at least generally how people transition will give better patient care. Understanding policies relating to sport and gender are going to help all athletes benefit from sports. When we're looking at literature, keep looking at literature, keep trying to get more studies out there. Just remember the limitations and the complications of these studies. Transition, especially in regards to sport, it's different for every person. There's unique challenges. It depends on the sport. The level of sport matters. So a 5-year-old soccer player for inclusion is different than a 20-year-old Olympian. And discussions regarding gender diverse athletes, and I really want people in this room to take this home. They're many times void of the sports medicine voice and the understanding to the nuance of athletes and the nuance of sport. And so the more we can speak up, the more we can be knowledgeable, the more we can try to do the best thing we can for all of our athletes. So what can you do? Remind yourself always of our own internal bias. Remember to do things based on evidence, not just on opinion. Know common gender affirming hormones. Know how they might affect your athlete. Be a resource, be an advocate, especially in regards to policies and rules and participation. It's hard. Give space and inclusivity to gender identity. Work on your language, making sure you're inclusive, and most importantly, engage in conversation. One of the kind of best learning tools that I've come with is when I'm in conversation, reminding and really trying to clarify what level of sport are we talking about? All of us work in sports medicine. Levels are very different. And then what aspect of sport are we talking about? Because they're very different. They're very complicated. There's lots of different discussions for each level. Finally, I'll just finish with a quote from Laisha Clarendon. And this was from her ESPN cover story. I feel very woman, I feel very man, I feel very both, and I feel neither. And I feel like all the gender expansiveness that exists in the world is in me. I think that's what the word trans means to me too. It's such a beautiful word. It's such a beautiful community that's full of resilience. And it just feels like magic. Thank you. Wow, we have 9 minutes left. I'm happy to answer any questions. Looks like Gina has a microphone if those want it. Yes?
With cis females typically often having testosterone levels that might be higher than under 10, are you seeing that for the trans men athletes, that there's sexual dysfunction or other unwanted side effects when they're trying to get the level they need and meet the criteria for an organization?
You need to say that again?
Or sorry, for trans, I said the wrong word, just
Okay.
for trans female athletes, when you're trying to get the testosterone really low, lower than a cis female athlete, are you encountering that those individuals are then having other problems with their sexual function or?
Yeah, absolutely. That's one of the most common side effects of medications are that we have sexual dysfunction. Sometimes we end up having to add, medications like Cialis and Viagra in order to allow that. But that is something we absolutely see. And then you also talk about cis women and our varied testosterone levels. We don't check testosterone levels. Oh, thank you. We don't check T levels in cis athletes. And that one study did look at it, and that was wonderful. But as you can see, there is variance when we look at that. And so when we're asking our trans athletes to go into these levels, it's also like there are some people that are outside those levels on their own without any gender affirming hormones. Yes.
If these policies, when you draw the lab, does that matter? I know for when you're providing gender affirming care, you try to do the mid-level. Is that something that they're consistent with?
Great question. These policies don't say that. which for those of you that provide gender affirming care, most of the time testosterone will peak over the time that someone is taking it. So if I want a very appropriate level for someone taking testosterone, I do it mid-injection cycle. So if they're an every 1 week testosterone taker, I like day 3 or day 4. If you're every 2 weeks, you're at day 7 or 8. So if I'm asking to get a testosterone level from someone, you probably should note what day you want it, because testosterone levels are changing in our bodies. So that's a great question. The policies don't denote that. But for those of you that provide gender affirming care, you probably know that those levels can change exactly where you're taking that level from and how far post-injection you are. Yes?
The community that UCSF has is pretty extensive. Are you having committee members, like especially I saw sometimes it's another student athlete who's on it, how are you protecting the confidentiality of trans athletes who don't want to be a public figure and just want to live their life when you have to have a huge committee?
Yeah, great question. Yeah, this is the Trans Student Athlete Participation Board is UC Berkeley. We do everything de-identified, and it's up to the athlete if they want to be there, if they want it de-identified, if they want their coach there. And so we do everything de-identified without names. We do end up having to identify the sport just because inherently we need to look at levels for that sport. But yeah, we try to make it de-identified because many athletes don't want the world to know, and that's their privacy. Yes?
How are those hormone levels per sport made and standardized? Like, how do they go about determining what's appropriate for field hockey versus volleyball versus
Yeah, great question. It's up to each national governing body. So each national governing body is getting together, trying to determine what they feel as a great level. Most of the levels are 10 and 5. Women's water polo, for some reason, uses 2.5. Where they got that number from, each national governing body goes through their own research process. But yeah, that's where they come from, and it's 2.5, 5, and 10. I haven't seen anything beyond that. And I assume they're going to continue to change. They're going to continually reevaluate and see where those levels are. Hopefully, as more data comes out, it'll be more useful. Yeah. Yes?
How do you approach that conversation with the patient? I'm thinking more like outside of California. If they come in with some paperwork that is required by the school or somewhere else, like knowing that how that information can be used punitively, so like making sure that the patient might be aware, you might be aware what you're signing up for, and sharing information.
So there's patient-doctor confidentiality, and then say if I'm filling out a form for the NC2A, that form is protected medically, and there's a way that we send it to them. We fax it to them because no one's hacking into fax machines. But that is protected part of their medical. As we all know, things are not perfect, but it is all supposed to be protected. Most of the athletes that we're talking to are very wary of the world in general, and so it is a very sensitive conversation. We have plenty of athletes that don't come out, that don't transition or wait until they're done because they just don't want to deal with it or don't trust the process, honestly. Any other questions? Yes, Cindy.
Thank you, number one, for this great talk. One of the last studies that I think that the important thing to realize, for all of us to realize, it's really hard to do research on this because there's not a lot of athletes that are, in the Hamilton study, which is the last one that you quoted or that you referenced, they were done in 30-year-olds, right? So they weren't done via Thomas as the elite athletes. They were done in transgender participants who were of an older age, in their 30s. So it's hard to extrapolate those results to people who are athletes who are in their 20s or in their late teens. That's a point. The second thing I want to say is the disorders of sexual development is huge topic that I'm disappointed you didn't get to that, Amy. I mean, I just feel like if you would have talked another hour, maybe I'm kidding. But that is a huge issue, and it's in our league right now, the NWSL. But it's going to be, and I will just say, 20 years ago at Cal, I had an athlete who came in whose parents called me in advance to say she does not know that she had surgery as an infant. And we don't want you to tell her. And I'm like, and so this is really real. I mean, the fact is that I think that the positive, there's gonna be more awareness, and I think with more awareness, hopefully there'll be more education and there'll be more understanding. But we're really early in this sense. And last thing is a lot of NGBs do not have medical professionals that are setting these guidelines. And so the people that are setting these guidelines is very oftentimes politicized. And when they say, what's the research? There's not a lot of great research out there. And so hopefully there are definitely leaders in the field that are trying to do really good research. Joanna Harper's one of them. But there's some really good people out there. So hopefully in our lifetimes, there's going to be less in our lifetime. There's going to be more understanding and more more just opportunities afforded to people who want to identify with gender, which they want.
And I think that's why I want people to engage in the conversation. Many times we pull back because, one, we don't know if we're going to offend someone or say something wrong, or we just don't know. We don't know what's out there. We don't know. Now is the time for us to engage as part of a sports medicine team to help make sure that kind of we're doing everything we can for fairness and inclusion, and really making sure that, yes, appropriate studies are being done or are being quoted, and what makes sense in regards to sports, because sports aren't all the same. There is not one particular thing that makes you a good athlete, and a lot of our athletes are different. They are not part of the mean. And so it's really, how do you kind of get all of that while providing this inclusion?
Awesome. Thank you, Dr. Hockenbrock. I think we'll end on that high note. Thank you so much for coming to speak at our course.